Sure. Hi everyone, I'm Jayatri Das, Chief Bioscientist here at the Franklin Institute, and I'm joined today by my colleagues Derek Pitts, our Chief Astronomer, and Rachel Valletta, our Environmental Scientist. And we're here today to talk about the thing that everyone's talking about. We're on your behalf. We are absorbing the fire hose of information that's out there about this novel coronavirus, COVID-19, to help you make sense of it all, because we're thinking about how it affects us here at the Franklin Institute day to day, of course. We are here wiping down every doorknob and cleaning every button you push on every interactive in our exhibits. And, you know, come visit us if you're looking for something to do and to learn about coronavirus. But for those of us who aren't here in the museum, we wanted to talk about some of the questions that we've been hearing from people, because there's a lot of information out there and it's really confusing. So let's start talking a little bit about, you know, our own perspectives on it, because, you know, I'm a biologist, so this is right up my alley. But this story really goes beyond just the biology of it all. This is that kind of science communication stories that really breaks boundaries.
That's right, and it's sort of under a microscope, because it's not just good or bad science communication practices that we're seeing happening. It's, of course, through the lens of public safety and public health, right? So I draw the analogy of the danger of purported disinformation, but really misinformation can be just as dangerous. And it doesn't matter if it's a public health issue, or in my case, I think a lot about climate change. Derek, I know you were mentioning this is the case also about a number of astronomical phenomena.
Yep, absolutely, sure.
Do you see this sort of, I mean, I guess this question is to both of us, do we see these moments of confusion where rampant misinformation sort of just tornadoes out, spirals out, and really spirals? And is that of concern, Jayatri, in this particular case when we're talking about a health threat?
Right, absolutely. Derek, do you want to?
Yeah, I'll just jump in with a couple of that I've seen in the astronomy field. You know, the first one that comes to mind for me, as I said just a few moments ago, just before we got started, is the whole supermoon idea. You know, we all love the idea of superlatives in astronomy, and the supermoon one is one that's emerged recently as being something that people have jumped on board with, this idea that the moon, when it's at its closest approach to Earth, appears so much bigger and larger and brighter, when in fact the differences of that close approach to the moon really aren't all that much. And there are ways that you can simulate this, but because of the way that this has been presented, it seems to be a new and great and wonderful, miraculous thing. So where is this, you know, where is the hype about this valid, and where might it be getting blown out of proportion? And, you know, when it comes to public health, that's obviously an extreme concern, because now, you know, it's not just headlines. Right, and it's not remote. It's not the moon out there. It's like us right here.
And people's lives are at stake. Yeah. And so it is really more about helping people understand data and how we think about these kinds of problems. And the challenge with this particular type of science is that if everybody works well and understands the data and does the precautions that we should, when it's all over, the reaction should be, well, that was a lot of hype. Yeah. Because if we do the right things now, then hopefully it won't be a big deal.
So before we get into what some of those right things might be, you mentioned data there. And we've been hearing a lot of numbers floating around about fatality rates and 0.2%.
Can't wait to jump in on that, yes.
I mean, so clarify that for us, going off right here. We've got a couple questions written down, and then we'll open it up, of course, for folks out there on Facebook to join with. Tell us a bit about the fatality rate value in particular. We've heard a lot of news coverage and a lot of government officials using these numbers, but they're not always consistent with one another.
Right.
So what are the most reliable numbers that we're seeing from health organizations?
So let's start there, because there are all of these questions about what is the case fatality rate. And statistically what that means is that when you have a disease spreading throughout the community, how many people get it and what % of those people eventually die from the disease. So that's what a case fatality rate is. Now, in the best of circumstances, when you have both the the numerator and the denominator, let's take that math class and do some fractions. If the numerator is the number of people who die and the denominator is the number of people altogether who have the disease, in the best of cases where you have those numbers can actually change dramatically for a number of reasons, right? That percentage changes based on the age of the population, and we're seeing that with this disease, is that older people are more at risk. We're seeing that number differ based on whether based on the proportion of the population that might have pre-existing conditions like diabetes or heart disease in particular. But there are also variables that are not inherent to to the disease that affect that number. It's how many hospital beds do we have to take care of people who get very sick. It's how quickly we can test people to find out that denominator of how many total people have the disease. And I think that's been the biggest challenge. Because what we're seeing from country to country is that different countries have different capacities to test different people, and unfortunately the US is not leading that list. So it's very hard to know what the impact of the disease here is. But people are looking to South Korea as a really good example for how to lower that case fatality rate, because they did very, very widespread testing, and they brought their case fatality rate right now down to less than 1%.
Okay, can you compare that to the regular flu virus?
Right, so the regular flu virus, our best guess is about 0.1%.
Okay, and the other thing I want to know about that is that, if you are changing the numbers that way, how are the numbers changing that way? Is it that more people are being treated, or that you just have a bigger batch of people that you're selecting from?
Right, and the answer is yes.
Okay. All right.
Right? So if you look at, Korea versus China, for instance, China looks like it's over the hump. Right, the number of cases that are new cases that are appearing in China is now going down. In Korea, they're a little bit behind that. So that number is still changing because there are people who are still in that period of really suffering from the disease, and we don't know whether they will ultimately die or not. So that's changing the numerator in Korea.
Right. So we're talking about numbers here. It's complicated and scary, right? And of course we should apply a lot of empathy to that. And the value you mentioned there, and correct me if I'm wrong, 0.1% fatality rate for the flu virus that we're familiar with, and somewhere around 1%, at least out of South Korea, for the coronavirus.
At best.
At best.
That's the best data that we have, but it could be much higher.
Right, okay. But we should still note orders of magnitude, 0.1 and 1% are drastically different.
Yes, of course.
Right?
Right. So this is why, let's transition a little bit to talking about what we can do and what this means as we're trying to process these numbers. Right, so even in the US, that 0.1% translates to tens of thousands of people every year. And our healthcare system has, roughly has the scope to accommodate that level of treatments. What's different about coronavirus is that it's completely new. We don't have a vaccine for it, and people around the world have not been exposed to it yet. So everybody could pick it up. As opposed to the flu, where the more people who get the vaccine every year, the higher the threshold that we have to buffer people who either can't get the vaccine or are particularly vulnerable. We don't have that buffer for coronavirus yet.
Okay.
So now that brings up another question for me, though, that is almost directly related to this in like a couple of different ways, and that is, can you talk a little bit about infection rates and how infection rates can change depending on what we do or don't do?
Yeah. So let's talk about some of the symptoms first, and we'll kind of build up to what that means for infection rate.
All right.
So the symptoms are most commonly fever and a dry cough. Sometimes you see some more respiratory symptoms as well, but all of this is coming from the fact that the virus is infecting the lungs. So that's the root cause of this. So what that means is that the most common way that the disease is transmitted from one person to the next is through close contact. It's from those droplets, when you breathe out or when you talk or when you sneeze, that are being expelled into the air. When those droplets then end up in somebody else's respiratory system, that's how the infection transfers. So I think that's important to know for one reason, is that the idea of maintaining some distance between you and a sick person is important, because that's one way that you can reduce the likelihood of transmitting that disease. But the other thing to point out is that this is not like a disease like measles. You can't catch this disease just by being in a room with somebody. Okay. Right? Measles is very, very infectious because it is airborne. Most our understanding of coronavirus, this particular coronavirus right now, is that it is largely spread by droplets.
Okay. So one clarifying point there then, you mentioned we've been sanitizing just about every inch of this building twice a day now. And when you mentioned droplets there, do we know if I cough or sneeze and I have the disease on a tabletop?
Yeah.
How long can the virus survive on a light switch or a tabletop, such that the next person that comes along and touches the surface may inadvertently transfer the disease?
So it can last a while. And I actually read some interesting preliminary data about how that can actually depend on what type of surface it is. In terms of how the interaction between the surface and the virus can actually affect the integrity of the virus. The nice thing, though, is that these viruses, they are covered with a coat that encloses the genetic material inside. That's actually pretty easy to break apart.
Okay.
So any kind of general disinfectant will break that outer envelope. So yes, it can stay on surfaces, but if you're cleaning regularly, that's effective.
Okay. And we've heard a lot, we've been joking about this, we've heard, is 60% alcohol wipe okay? Is 90%? Can you clarify for us, for some of us out there using hand
Urban, or are we going for the Everclear?
Yeah, which vodka company was it that was putting out a public service announcement that our alcohol is not actually high enough concentration.
So if we'd like to effectively
60% alcohol.
60% alcohol wipes are okay.
Yes.
Okay, and regular hand soap, antibacterial, there's been a lot of questions about this as well.
Yeah, so regular hand soap is absolutely the best. Again, the ingredients in soap interfere with how that coat stays together. So again, that 20 seconds of hand washing, the soap, the warm water, all of that, really effective.
And can we just go back and mention that, you said 60%, Rachel. If you go into a drugstore and you buy a regular bottle of isopropyl alcohol, it's easily 70% or more.
Yes.
So if you just go buy a regular bottle of alcohol, you're in good shape.
Yep. Yeah, all those online recipes.
Yeah, exactly. All the online recipes.
As long as 60%, you're good. But getting back to your question then, now we're hearing a lot of discussion about this term of social distancing. So as we've discussed about what it means in terms of how the disease is transmitted, that helps us understand why that literal putting distance between you and somebody else is a really effective way to start lowering that transmission rate. And so this then starts to bring up this idea of how do you weigh individual risk versus community risk? And I think this is where human nature is not very good at determining risk. There are so many psychological studies that talk about how we are just based on how we are trained in our society, how we survive. We look at immediate personal risk before we think about long-term risk, for instance.
Or widespread risk.
Or widespread risk, right. This is particularly relevant when it comes to something like climate change, right? That we're not good at thinking about what climate change means to us because it seems like
a
long-term, faraway risk.
We use the term discounting the future.
Right.
It's from the behavioral economics literature, actually. I was just about to say that 0.1% doesn't seem, or rather 1% doesn't seem so scary, right? 1 out of 100, that can't possibly be me, right? It's very similar similar calculation that folks make when we think about long-term unfolding issues when it comes to environmental concerns.
Right, and you know what, it's interesting you mentioned that, Rachel, because one of these other instances in astronomy that sort of goes along with this is this idea of what's the percentage chance that a particular asteroid is going to come close enough to Earth to do some serious damage.
Sure.
And you know, the thought is, well, it has a 20% chance that this could happen, but it's 300 years down the line, so I don't have to think about that right now. Yeah, but 100 years from now, 300 years from now, the people that are here are going to be really worried about that. So can we think about some kind of mitigation now that will help further down the line? Maybe not. It's 300 years from now. Do I really want to invest time and money in that?
Right,
in this particular
instance, case.
Right, I think it's really important, and it's one of the things that really interests me about how we share these messages and how we each think about our own risk and responsibility to all of the rest of us.
All right, and looks like we've got an audience question here.
Yes, we have gotten several. One of those is, how are people contracting the virus even when they have not been in contact with an infected person?
That is an excellent question, and that's the big mystery right now, is that, so one thing when a case, that happens when a case is documented, is that public health officials will try and do something called contact tracing. And contact tracing is trying to think about where this person has been, who they might have caught the disease from. But there are cases that we just don't know. And when you find a case like that, that's when you start being worried about what we call community spread. That it's just out there in the community. We can't trace it to a direct point of contact of infection. So if we can't trace this person, there's probably a lot more people who have been exposed. And that's what we're seeing in Washington State right now, is that the first cases in Washington State were able to be traced. But then they found cases that we didn't know where they had come from. And this is where there's some really interesting science going on here to figure this out. Because there are scientists who are sequencing as many genomes of different viral infections as they can get from all over the world. And if you're interested in the raw data, there's a great website called nextstrain.org if you're a nerdy evolutionary biologist like me, where they're tracking how the virus is changing. And where that comes back into a very practical application was when they sequenced the genome of the virus that had infected this community spread case. They were able to look at the changes in the genetic sequence of the virus, compare it to a sequence from somebody who had gotten it from direct contact, and then calculate how much time had likely passed to accumulate that many changes in the sequence.
Wow.
And when they did that, their estimate was that the virus had been in the community for about 6 weeks.
So just to clarify there, so there are genetic changes that are always happening?
Their DNA is always changing. DNA, RNA, genetic material is always changing. And you can calculate the rate of change over time to get an estimate of how long it's been since two sequences were originally derived from the same ancestor sequence. So it's a really interesting application of evolutionary biology to get a sense of how a virus has been circulating within a community. And so that's really when the concern skyrocketed.
So, next question. Can you catch it more than once? Can you recover and become reinfected?
All right, this is some good news. So the best data that we have right now is coming out of China, and for the most part, there are no cases of reinfection that are significant. There are potentially some questions around false negatives that in the testing process, but when you look at a population scale, it doesn't seem like people are getting reinfected, which is fantastic, right? So it does seem that people are building up immunity to it. So our immune systems are able to fight it off and then keep it off. So that bodes well for the ultimate long-term spread of the disease.
And one more question before we take it back to
we've got plenty of questions.
where your timeline there. How long are you contagious, especially before you show symptoms?
That's a really good question, and that's kind of the worrisome part right now. So on average, the time from contracting the infection to showing symptoms seems to be about 5 days. Can range anywhere from roughly 2 to 14 days that we're seeing. But it's that 5-day window where you may be shedding the virus and infecting other people before you realize that you have symptoms.
And that adds, I think, a complication to what we were talking about earlier about testing. There's the question of availability of tests and how quickly they can be processed, but it's also a question of how quickly you go for a test in the first place.
Yeah, and also in terms of the public health criteria, in terms of who's allowed to get a test, right? And we've seen that here in the U.S. that our criteria were very stringent at the beginning. That basically only people who had some direct contact with travel from China were being tested until we started seeing these signs of community spread. And as the criteria are relaxed and more people get tested, this is where we're seeing these wild swings in some of the numbers. Of course, that depends on tests being available.
I was going to say.
And that is now a challenge.
That's a big piece of this, is the number of tests that are actually available.
Right.
Yeah,
so even though this starts out as a health problem, we quickly see how it snowballs into many different sectors of our society. And those are some of the long-term impacts that we're going to be dealing with for a long time.
This also brings to mind for me that this is the first time I can recall having seen an instance where we're asking for so much of the population related to a particular health crisis.
Yeah.
Not to say that this hasn't happened in the past, because by now we've all heard of the 1918 flu and things like that.
Where Philly did not do the right thing.
But here's an instance where there's so much being, because it's so new, there's so much being asked of us in relation to this, and it puts a great deal of pressure on the healthcare system because
right. So I'm glad you brought that up, because another term that we wanted to talk about that has been in the media lately is this term flattening the curve. So this is a public health concept that I think it's worth getting into. So normally when you see a new disease being introduced into a naive population, you see without doing any kind of precautions against it, what you see is a very sharp, very high peak as everybody gets infected from the disease. And if you think about the available resources that we have in our healthcare system, if you have a very sharp, very high peak, that will overwhelm our ability to treat people. Now, with some of these social distancing and other precautions, all that hand washing, what we do is we spread out that infection over time. So even if you have ultimately the same number of people getting infected, if you can change that curve from a sharp high peak to a much broader curve over time, then we can keep that below the level of resources that we have available to treat.
And this is because what's actually happening is when people actually wash their hands and do the social distancing, the rate at which the virus can be transmitted drops dramatically, so it spreads it out over a longer.
Right. So essentially, the mindset here is that we know it's here, we know we can't stop it, but let's slow it down.
Let's give ourselves the best opportunity for the healthcare system to catch up.
Exactly. I've seen analogies like let's put some slack in the system. Right. If we stress the system higher than it's capable of, then we're going to have much higher fatality rates.
So this also comes back to this idea that we have to, as humans in our ways of dealing with risk, we have to take this into our consciousness and understanding of what we're doing as individuals and how it helps the population overall.
Right.
So we have to not only think about it from a personal point of view, where you want to wash your hands and keep your distance so you don't get infected, but you also want to do this so that you can spread how you can sort of put that slack into the system.
Exactly.
So that we all can have access to the healthcare system if we need it, if we get to that point.
Right. And so that's, I think, the biggest message here, is that every time you're washing your hands, yes, you're reducing your own risk, but you're helping everybody. And we don't normally think about that connection between individual actions and community impact. And you hear a lot about, okay, keep calm, and some people think that keep calm means ignore the problem. It's not as bad as you think. For me, what keeping calm really empowers me to do is to think about the fact that I can take concrete actions and make a difference in our overall response to this. That brings me some hope.
And in this case, they're very, very simple actions that can be taken as well, that can have a big and broad effect.
That is to say, it's still, though, acknowledging that those simple actions that we take still do have long-term, both positive and negative impacts, right? Like, we can talk about the fact that, yes, that helps, flatten the curve, that helps people who need care get care, but recognizing that there are economic impacts to that. There are, social impacts to that. So yes, they seem simple, but we're going to be dealing with this, for a long time. And I think we've got another question.
Yes, we have two more questions, actually. Two new ones. Once infected with the coronavirus, does it stay traceable like TB, or does one fully recover like with a cold or the flu?
That's a great question.
That is a great question. And actually, I'm not up to speed on where we are with the latest version of that. So the tests that we have right now are based on being able to detect the active virus in your system. So through a blood test, through a swab, being able to find the virus itself. If we want to be able to trace the virus after after you've cleared it, then we need to be able to detect the antibodies or the molecules that your body produces to protect yourself against the virus. We need to be able to detect those antibodies. And I know there are groups around the world who are working on developing that kind of test. I think there was a group in Singapore, I think last week when I wrote my last blog post, that had just started testing that, but I'm not sure how far that's progressed.
And then another question we have is, do we think warmer weather will halt the virus?
We don't know. I think that's everybody's hope for a best case scenario, but we just don't have any data to suggest whether that's true or not.
But can you talk about the reason why that comes up?
So there are a couple of theories about why. I think we frame it when we think about flu season.
Yes.
Right. In the U.S., we talk about flu season starting to wind down by February or March. Some of that is due to just environmental reasons, that people start spending more time outside. We're spending less time in moist indoor environments. There are some questions about how temperature can affect the virus itself. So that's a reason that we might expect a virus to subside as the weather gets warmer, but we don't have any data yet. And there are certainly warm places in other parts of the world where the virus is still infecting people. The other thing to be cautious of is that viruses can reemerge, and you brought up the 1918 flu before, and that's a case where the first wave had subsided and then reemerged in the fall. So I don't think we have enough data to say with any kind of certainty that that's what we're looking at.
So I'm going to ask one more question and then let you guys get back to your conversation. This just came in. Do we know why the incidence of COVID in Central and West Africa are so low?
We don't. That's the short answer. I think there's a lot of people who are interested in that question. My sense is that there's so much effort right now being placed on finding ways to stop the active virus that we haven't yet put enough effort into understanding about why it stops in some places. And that could be because of migration patterns, it could be for environmental reasons, it could be just based on genetic variation. We don't have a good sense of why that's happening yet.
I have a related question to that, and it is, how long have we known about this particular coronavirus? And if we haven't known about it very long, does that say something about how much we know about it?
Right. So this particular coronavirus really started emerging in China at the end of 2019. So it's very new.
Just 3 months, a little more than 3 months.
Right.
Okay.
That being said, we also know that viruses evolve really quickly. So even though we couldn't predict this particular coronavirus, experts in public health know that there's always the potential for the next outbreak around the corner. Because just the rate of, again, those random mutations, the fact that coronaviruses seem to be able to jump between species, and so public health experts have put a lot of thought into thinking about how we prepare, because in their minds, the next outbreak is not a question of if, it's a question of when.
So is there a concern then that there could be a mutation of this particular strain, this COVID-19 strain?
So as we think about different treatments and things like that, we know that the virus is mutating. We have that data. And the question is, as people are working on vaccines, as people are working on different drugs that might be able to treat it, let's look for the parts of the virus that don't change as frequently, and target our vaccines and treatments on those. I've got another question.
Yeah, so the World Health Organization has declared this a pandemic, and I wondered if you could clarify the difference between an epidemic, a pandemic, and what the threshold is for something to be declared one of those two.
That's a really great question in terms of some public health terminology. An outbreak is where you have a high number of cases emerge in a very localized area. An epidemic is more than that when you start seeing it in multiple areas. A pandemic is where you see it spreading across the globe very quickly.
So we just had something come in. Did I cut you off?
No, go ahead.
We see some young people with no underlying conditions getting sick. Are scientists investigating some kind of genetic predisposition that makes other people otherwise considered low risk at an increased risk for serious disease?
That is a great question. I don't know the answer to that. There's so much research going on that there's probably somebody out there who's looking for this. But I think the priority right now is, from an entire field perspective, is how do we help the most people in the fastest amount of time. But to that point, one of the individuals that has been representative of the story that we're dealing with is the young Chinese doctor who first really raised the alarm about this disease in China, and then ultimately died from the disease. Obviously he was exposed to many patients, but seemed to be young and healthy. So obviously yes, that's a concern.
So.
All right, so where do we go from here?
Where do we go from here?
This is where we end this
great
conversation. Yeah.
It's great to know all this, but now what do we do?
Where do we go? In Philadelphia, we just had the first confirmed case of COVID-19 appear yesterday. As these individual cases pop up, I think we're seeing a greater sense of urgency, because how fast can you contain the spread of the disease in any one area, and when you move from containment to what we call mitigation, is how you then just focus on, once you can't stop it, how do you flatten that curve? And so this is where we're seeing all of this messaging about staying home, about canceling large events, that these kinds of precautions will help flatten that curve. Because the more we can do that, obviously the fewer people, hopefully get sick, and the more our system's able to take care of it. I think the biggest immediate need right now is to ramp up our testing capacity here in the U.S. When you go to, I think COVIDtracking.com is a really collaborative, crowdsourced volunteer effort to track testing and positive and negative cases in every state. That's updated every day. It's where I've been going to look at the numbers. And you look at the numbers in the US and we don't even begin to compare with countries around the world. So how do we ramp up our capacity for testing? Because that will give us more information. And I think that's where I want to wrap up this conversation, is because the best way that we can prepare people is to give people accurate information.
Right. So you mentioned that tracking website. Could you say that again for us?
Yeah, COVIDtracking.com.
COVIDtracking.com. Where else can we go for other public health specific information?
Right, so there's a link in my blog post, and we can post it in the comments, to a tracking website that's put out by Johns Hopkins University. It has a really unwieldy URL, so it's hard to just spout off. But that in real time is tracking global cases. So it's a pretty complicated snapshot that is really interesting in being able to look over time at how the impact of this disease is spreading in different places. But again, all of that is based on having accurate information. And I think so much of the worry around this disease is in the absence of that information. So the more testing we can do, the better a handle we have on how many people are getting infected, how many people are recovering, where are those people located around the country, the better we prepared that we can be. And ultimately, my hope is that in 6 months, we'll look back and say, all right, well, that wasn't as bad as we thought it was going to be.
Hopefully.
Right? But it will only be better than we think if we over-prepare now. And I think that's the trade-off that people have to be okay with, is that it may feel like hype now, but if we don't take it seriously, there's that chance of the meteor hitting Earth 300 years from now that will happen without us being prepared for it.
So on an ending note then, the best preparedness measures we can take: washing our hands, social distancing, consideration of quarantine.
Yes, if you're feeling sick, stay home. Keep your distance from other people, absolutely.
And have we missed any major preparedness step that we should take? It sounds like right now it's about staying calm and being active.
Yes.
And being proactive, right? About some of those preventative measures.
Yes.
I think look to your local public health officials. For me, it's our county that's looking at the relevant data and giving guidance as to what we should do, because we know this geographic spread goes radially, and so knowing what the important steps are in your community is the most important. And the other thing, getting back to the point that we're all in this together, that we're all looking out for each other, make your backup plans. So if you do get sick, who can you call to help you out? And when somebody else in your community gets sick, go help them out.
That's great.
We're all in this together.
Yeah, absolutely.
Thank you.
All right, I think that's a good place to end. This situation is changing so rapidly that when there's more to talk about, we'll be back. Thanks for joining us today.